This is a video lesson on procedures of the chest. To begin with room setup, we have 40-inch SIDs recommended for soft tissue neck radiography, and 72-inch distance is recommended for chest radiography. Two of the reasons for 72-inch distance is for the chest radiography is to minimize magnification of the heart and to increase spatial resolution of thoracic structures. A third one is that it does decrease patient dose. We always use our ID marker for all images, and then we also shield for both the soft tissue neck and the chest radiography procedures. Soft tissue neck images can involve both an AP and a lateral projection. In the AP projection, we're going to evaluate the cervical spine or soft tissue next to the anterior neck. We could be looking at pathologies such as foreign bodies with swelling, especially the epiglottis. They could be evaluating masses, larynx fracture, and hyoid bone fracture. The exam can be performed upright or supine. When you look at the position of the part, you want to center the mid-sagittal plane to the midline of the image receptor and adjust the shoulders to line the same transverse plane. Extend the neck slightly and adjust so the mid-sagittal plane is perpendicular to the image receptor. Now, if you're going to be looking at the upper airway, we're going to center at the level of the laryngeal larynx, which is about C4. And for the manubrium, if we're going to look at the lower soft tissue neck airway. So we're going to position so that we're perpendicular to one of those two levels. We're going to make sure that we have our collimation open 12 inches lengthwise and 1 inch beyond the skin lines, but no greater than 10 inches. We want to see an air-filled upper airway or trachea and superior mediastinum. These are images of the upper and then lower airway showing the air-filled trachea. We want to see no rotation, spinous processes equidistant to the pedicles and align with the midline of the cervical bodies. On the lateral projection, we're going to do something very similar to the AP. The patient is typically standing upright or seated before a vertical grid device. We're going to equally distribute weight. They're going to clasp their hands behind their body and rotate their shoulders posteriorly as much as possible. We're going to center to the airway to the midline of the image receptor, and we're going to center at the same locations as we did for the AP. For the upper, it's going to be at the laryngeal prominence, and at the lower airway, we're going to center at the level of the manubrium. We're going to position this so that our respiration is going to be slow inspiration, and we're going to go center is going to be the mid-coronal plane at the two levels that we just discussed. Our collimation is the same as the AP, and we're still going to see that air-filled upper airway or trachea and superior mediastinum, and it can also be used to locate foreign bodies. Now looking at the two images, this one's the upper airway at the very top and the lower airway at the bottom. So we're looking at the two different possible images, and we're looking at the no tilt or rotation of the cervical spine. Now, patient positioning in terms of the chest, we want to make sure that the patient can walk on their own if they're ambulatory. We can do this standing or seated erect. If they're non-ambulatory, we can perform chest radiography with a wheelchair or the stretcher. And the big thing is we would like the patient to be erect because we'd like to see air fluid levels. It's very important. If we cannot do the image with the patient erect, then a decubitus position can be used. So parts of the heart and the lungs are all labeled here in this image just for review purposes. We've got the trachea, which is A. B is the left apex. We've got the carina at C, which is also called the tracheal bifurcation. D down here is the base. E are the hemodiaphragms. F is the costophrenic angles. There's one on they're bilateral. And then the hilum at letter G. On the lateral projection, we have the apex at A, the upper lobe at B, the hilum at C, which is typically circled. We'll see that in a few slides ahead. The lower lobe is at D, with the base of the lungs at letter E, and the diaphragm, hemodiaphragm, technically at letter F. Looking at the two different levels, the diaphragm, since the right diaphragm is slightly higher, 1 inch higher than the left one. Patient instructions, we want to give the patient good instructions, let them know exactly what we want to do. Something that's very important and vital is we want to have full inspiration, which is in other words, double or deep inspiration. We want to speak slowly and watch our patient, and we may need 2 radiographs. In other words, we may not always want just inspiration. We may need images for inspiration and expiration. It could be, we could look at the pneumothorax, the diaphragm movement, presence of the foreign body, and then the atelectasis are reasons for inspiration and expiration images. Now on inspiration, air is taken in. The diaphragm is going to move down, which is what is being shown in blue. So the diaphragm moves down, and when we do that, we're going to see that the ribs swing outward and upward to allow for increased transverse diameter, and the AP depth increases as well. In pink, we can see what happens is that as we go on expiration, air is released and then the diaphragm moves up. And so the transverse diameter decreases, the AP depth decreases as well. On the left-hand side, we see the image on inspiration. We want to see a minimum of 10 posterior ribs on our image. And the right-hand side, we see an image on expiration where the diaphragm has moved up. On the left-hand side, we see an image that's been properly positioned. We can see that by looking at the sternoclavicular joints are equidistant. Specifically, the clavicles to the vertebra are equal on both sides. And then on the right-hand side, we can see that there's a bigger distance on the patient's left side. So this is showing showing a problem with rotation. So SC joints must be equal on both sides. Chest projections, we're going to take a look at the PA, the lateral, the AP supine or upright, the AP lordotic, the AP axial, and the lateral decubitus. You can also perform mobile radiography too, which would be the same as being an AP supine or upright. So in the PA chest radiograph, which is your normal image as far as protocols, we're looking for pleural effusions, pneumothorax, atelectasis, or infiltrates. The patient should be upright, standing, or seated. They should be facing the image receptor. And something important, the same as we do for thoracic spines, is we want to have the upper border of the image receptor 1.5 inches to 2 inches above the relaxed shoulders. We want the mid-sagittal plane of the body to the midline of the image receptor. The weight of the feet on the body should be distributed equally on the feet. Extend the chin upward and adjust the head to the mid-sagittal plane as vertical. Flex the elbows and then place the backs of the hands low on the hips. Depress the shoulders and rotate the shoulders forward, and that's going to remove the scapula from the lung fields. And that's very important to get the scapula out of the lung fields. We want to perform this on full inspiration. We want to be at the level of T7, which is the inferior border of the scapula. We want to have our image open to 17-inch lengthwise and 1 inch beyond the lateral shadows, but no more than 14 inches. Now, however, you can have a patient that you may have to do a landscape mode too. We're going to look at a PA projection of the thoracic viscera with the air-filled trachea, the lungs, the diaphragmatic domes, the heart, the aortic arch, and if enlarged laterally, the thyroid or thymus gland. So we're looking at the evidence of collimation. We're looking at the lungs from the apices at the very tip top down to the costophrenic angles must be included. And so very important. You want to make sure we have no rotation, which is shown by the sternal ends of the clavicles being equidistant from the vertebral columns, or SC joints are equal on both sides. And we can also see that we have the scapula out of the lung field, so we have rotated our shoulders forward and gotten those scapula out of the lung fields. The lateral projection should be upright, if not standing than at least seated, but a true lateral without rotation. We went to mid-sagittal plane parallel with the image receptor. We went to mid-coronal plane perpendicular and centered to the image receptor. We want the arms above the head and flex the elbow, and we want the height of the image receptor the same as it was for the PA projection. The mid-sagittal plane must be vertical. We have the same respiration and we have the same central ray location as we did for the PA projection. We also had the same collimation. On the structures shown, we have the left lateral with the heart, the aorta, the left-sided pulmonary lesions, and the right is the right-sided pulmonary lesions. So looking at the image, we can see the hilar region in the center of the image. And that's the one thing that wasn't noticed that was wanted to bring up, just showing here. Our sternum should be in profile. We should see looking at that, and we should see the trachea as well in the image. Looking at the trachea coming right over here, and even the air-filled esophagus is shown in this patient. On an AP projection, the chest might be taken when a patient is too ill to stand or to stand, or to sit or to stand, excuse me. They would be supine on this table or the stretcher. They would center the mid-sagittal plane of the chest to the image receptor. You want the upper border of the image receptor the same as it was for the PA and for the lateral. If the patient's condition allows, you're going to flex the elbows and pronate the hands to place the hands to the hip to draw the scapula laterally to get the scapula out of the lung fields. You want to use the same respiration as you did on the last two images and the same central ray location, except now since we're at an AP projection, we're going to center about 3 inches below the jugular notch. We're going to do the same collimation that we did previously, and we're going to look at the structures shown as being similar except larger. The great vessels in the heart are going to be magnified because we've got a shorter SID, and our patient also is recumbent, so therefore the clavicles are going to be higher and the ribs are going to be more horizontal. So looking at our image, in this image, we can see the scapula is not out of the lung field. So it does show that the scapulas are in the lung fields here. But we want no rotation, the trachea is visible to midline, and we've got the same structure shown as you did with the PA, except for that you may have the scapula image that the patient was unable to rotate their shoulders forward, as we talked about previously. The AP axial Lindblom method is one in which we don't angle the tube, we angle the patient. So in this case, the patient is about standing 1 foot in front of the vertical grid device, and you've got the height of the image receptor, so it is about 3 inches above the upper border of the shoulders when the patient is in the lordotic position. So this is what is called the lordotic position with this Lindblom method. Now, with a coronal plane to the thorax is about 15 to 20 degrees from the vertical, and the mid-sagittal plane is centered to the midline of the grid. We're going to use the same respiration as we have for the last several images of the chest. We're going to have this perpendicular to the image receptor at the level of the mid-sternum, 3 to 4 inches below the level of the jugular notch. We're going to adjust our image receptor very similar to what we did with the PA projection earlier. And what we want to see are the apices and conditions such as interlobar effusions. So the image looks very strange. We want the clavicles projected above the apex of each lung, or the apices. We want to see the entire apices in the appropriate portion of the lungs. The ribs are going to be distorted with their anterior and posterior portions superimposed. An option, instead of doing the lordotic position, is to do an AP axial projection, which is not called the Lindblom method, and it is not a lordotic position. In this case, if you notice, the patient is standing upright and they're in an upright or supine position. We're going to center to the level of T2 this time. We're going to make sure that our mid-sagittal plane is perpendicular and that our elbows are on the hips, and we're going to pronate so we can get those scapula out of the lung fields. We want to go on the full inspiration again, but this time we're going to do 15 to 20 degrees cephalic or cephalad, and we're going to enter the manubrium. It's very important. We're wanting to see the apices above the clavicles, and this is a little bit safer position to perform rather than lordotic in case your patient is unsteady. And so here we go. So we've got the apices that we're able to visualize. They're located inferior to the clavicles. The clavicles are out of their way. We can see the apices in their entirety. The ribs are distorted, as we said before. Now, an option you have if a patient is unable to, unfortunately, stand up, or if you're looking specifically for pleural effusion and pneumothorax, something along those lines, you could do a lateral decubitus position, which is an AP or PA projection of the chest. So you're looking at having the patient lying on the affected or unaffected side, as shown by the existing condition. You want to make sure that if they have a pleural effusion, that you're going to show this with the patient lying on the affected side. And if they have a pneumothorax, we're going to have them lying on the unaffected side. You're going to have the patient lie in the position for 5 minutes before the exposure allows the fluid to settle and the air to rise. You're going to position so that the patient is, especially if the patient is lying on the affected side, you want to use a platform that's about 2 to 3 inches that they can elevate the body, on which they can elevate the body. We want to extend the arms well above the head and adjust the thorax in a true lateral position. This is not the most comfortable position, as you can kind of tell by viewing the patient at this point. So we're going to adjust so that we are going to do go about 1.5 inches to 2 inches above the shoulders. We're going to still do full inspiration as we have for all chest radiography. And we're going to be at the level of 3 inches below the jugular notch when we're doing an AP projection. And we're going to center to T7, which is the inferior border of the scapula, for the PA projection, if we're doing PA. So in this case, we have an AP projection. And we're going to look at a change in fluid position and reveals any previously obscured pulmonary areas or the case of a suspected pneumothorax in the presence of any free air. So taking a look at our two images, on this image we're looking at a lateral decubitus of the chest. The right side's down, so we're looking at fluid on the affected side, which is the side down. That's a pleural effusion, air in the pleural, or fluid in the pleural space. On the other hand, you could be looking at air, and this is a left lateral decubitus. So we're looking at the right side up, so the air is in the side up in this case, and therefore we're looking at the pneumothorax. All right, so if there's any questions that you have, just let me know. Otherwise, hope have a great day.